Hit the subscribe button or visit us at auau.auanet.org.
Good afternoon and welcome to Trimodality Therapy for Management of Muscle Invasive Bladder Cancer, presented by the AUA. We strive to offer outstanding educational courses and greatly appreciate your evaluations and general feedback so we can continuously improve our programs. We thank you for joining us. Before we get started, I'd like to go over a few items so you know how to participate in today's events. I'd like to extend a special thank you to our course director, Dr. Adam Feldman, for planning an excellent educational course. We thank you for your dedication and commitment to urologic education. Thank you as well to our faculty for their time, talent, and expertise for today's program. The AUA is accredited by the ACCME and designates these other activities, live virtual activities, and enduring materials for a maximum of 2 AMA PRA Category 1 credits. Evaluations are very important to us. Course evaluations and CME credit will be administered electronically on the AUA 2021 site immediately following the live program today. As the AUA continues to develop virtual education that meets your needs, we welcome your feedback regarding both the content and format of this activity. Please visit AUA2021.org to complete your evaluations and credit claim. All persons in a position to control the content of an AUA educational activity are required to disclose any relevant financial relationships with any commercial interest. Please visit AUA2021.org to view Faculty, Education Council, and COI review work group disclosures. The American Urological Association would like to thank AstraZeneca, Bristol Myers Squibb, and Merck for their generous support of this educational program. This activity is meant to be educational in nature and in some instances reflects the opinions of the presenters. The information does not guarantee accuracy of claims submitted. Please verify the accuracy of individual medical claims submitted and please follow individual insurers' rules. It is now my pleasure to introduce our course director, Dr. Adam Feldman. Dr. Adam Feldman is a urologic oncologist at the Massachusetts General Hospital Department of Urology. He is the director of the Combined Harvard Fellowship Program in Urologic Oncology and director of research for the Department of Urology at MGH. It is now my pleasure to turn the program over to Dr. Feldman.
Good afternoon and welcome. I'd like to thank the AUA for supporting our course and thank Dr. Nitti and the AUA Education Committee for, again, supporting our course and choosing us for this kickoff weekend, which I know everyone is very excited about. I'd like to begin and I'd like to introduce my colleagues and co-course faculty, Dr. Jason Efstathiou, who is a professor of radiation oncology at Harvard Medical School and Mass General Hospital. He's the director of the genitourinary division in radiation oncology and clinical co-director of the Claire and John Bertucci Center for Genitourinary Cancers, multidisciplinary clinic at Mass General. Dr. Rick Lee is a medical oncologist at Massachusetts General Hospital Cancer Center. He's an assistant professor of medicine at Harvard Medical School. He specializes in genitourinary cancers with a focus on biomarker development, cancer cell metabolism, and clinical trials. So with that, we'd like to get started. Just getting control of the slides here. Here we are. So our agenda today is to really go through the rationale for bladder-sparing tri-modality therapy. We want to talk about patient selection for either approach, the importance of multidisciplinary care, and how we go about implementing this multidisciplinary care, including maximal resection with TURBT, how we then go forward with chemoradiation, what are the chemotherapy options, what is surveillance, and how do we deal with local recurrences within the bladder, and then also discuss quality of life, biomarkers, immunotherapy, and other future directions. So organ conservation in oncology is becoming standard of care in multiple malignancies. In muscle-invasive bladder cancer, at this point, radical cystectomy does remain the most commonly offered treatment. And at this point, there are no completed randomized trials comparing bladder preservation TMT to radical cystectomy. And while most patients do well with surgery, it certainly is a major physiologically challenging surgery and can also be life-altering for many people. We know that this is really, as urologic oncologists, one of the most one of the biggest surgeries that we do, radical cystectomy, and has a high complication rate and a high readmission rate. And while we're trying to make efforts to minimize those, both with ERAS pathways and also with minimally invasive cystectomy, including robotic-assisted radical cystectomy, we really have not seen a major improvement in the complication rate and readmission rates. And these are data that were from the Memorial Sloan Kettering randomized trial and then have been supported by the more recent RAZOR trial. We know that urinary diversion, surgical urinary diversion, affects renal function long-term and can affect, and this effect on renal function long-term and declines in GFR can have implications in patients' other comorbidities and risks going forward in life. So these are really interesting data by Dr. Stathu and colleagues looking at the National Cancer Database, and he'll also comment on this study, but really speaks to the sometimes undertreatment of patients who have muscle-invasive bladder cancer. So if you look at this bar graph, what you see is these are patients who have muscle-invasive bladder cancer. The orange is surgical cystectomy. And then the blue bars here is really patients who do not have adequate or standard of care therapy. And you can see that as patients get older in their 70s, 80s, and 90s, many patients are not getting standard of care curative intent treatment for their muscle-invasive bladder cancer. And this is really an age group in which we can make an enormous impact. So what are the options for muscle-invasive bladder cancer? Radical cystectomy with or without perioperative chemotherapy, bladder preservation, which is a maximal TUR with chemoradiation, partial cystectomy, or maximal TURBT plus or minus chemotherapy. So we know that in the guidelines, including the AUA guidelines, and what I'll show next, the NCCN guidelines, we know that bladder sparing by tri-modality therapy or chemoradiation with TURBT is an accepted option for muscle-invasive bladder cancer. And in the NCCN guidelines, it's listed as a category 1 option for both clinical stage T2, also for clinical stage T3 and T4 disease. And also in our patient education literature, both from the AUA or Urology Care Foundation, as well as really the leading sort of bladder cancer advocacy network, our patients are reading about this as an option. So how do we proceed with TMT for patients, and how do we identify patients? The urologist plays a critical role in patient selection, also then in TURBT and eventual re-resection, and then as time goes along in repeat cystoscopic evaluation. So how do we select patients? The ideal patient would be those who have a tumor which can be completely and thoroughly resected. does not have hydronephrosis, and does not have extensive involvement of carcinoma in situ, and does not involve the prostatic urethra. So I list some cautions of tumor factors. And so we think about tumor factors versus patient factors, which we'll get to in a minute. But tumor factors in which are cautions include inability to achieve a complete resection, the presence of hydronephrosis, large tumor burden involving the majority of the bladder. And you can see the images, the CT images on the right upper part of the screen, which show really someone who's not a candidate, extensive carcinoma in situ, a high-grade tumor to bladder diverticulum, upper tract involvement, prostatic urethral involvement, and extensive bladder neck, really circumferential bladder neck involvement in women. That being said, not every case needs to be perfect. So some patients can have some adjacent CIS, which can be ablated transurethrally. They can have limited satellite tumors, and those can be certainly dealt with transurethrally. And it's not really about the size of the tumor. It's really about the extent of the wall involvement or the stalk. So there are also patient factors. Patients need to be able to tolerate concurrent radiosensitizing chemotherapy, and they can't be they cannot be a poor candidate for radiation therapy. They should not have had prior pelvic radiation. We avoid radiation in patients who have a history of inflammatory bowel disease, and they shouldn't have poor baseline bowel function, and certainly not have poor baseline bladder function. It has to be a bladder worth saving. So multidisciplinary care and coordinated care is critical. There's timing with the resection, chemoradiation, and then repeat evaluations that really must be coordinated in a multidisciplinary fashion. In addition, we communicate with our radiation oncologist the tumor location and the details about TURBT, and this is an example of a bladder map that we'll often use, in addition to having a detailed description in the operative note. That is very important so that the radiation oncologist can design their fields appropriately. And even sometimes Dr. Stathio and I, who share patients, will meet to decide and go through and convey information that I can convey to him about the patient and the tumor anatomy and the bladder anatomy. And this just is to comment on that it's standard of care, really becomes standard of care for multidisciplinary care in bladder cancer, in addition to really becoming a standard of care in the majority of GU oncology. Maximal resection is key to having a successful outcome. These are our data that just show that a complete TURBT leads to better outcomes in patients, and this has been confirmed by other centers. So how do we do that? This is a very much of a surgical approach, and I want to make sure that everybody on the call knows that. The goal of TURBT is to remove all visible tumor, not to just prove muscle invasion. Always, I do a bimanual exam to assess for fixation, induration, and assess the mass pre and post TUR. The technical considerations that we want to think about: general anesthesia. Sometimes you may need neuromuscular blockade to prevent obturator spasm. I do, especially for re-resection, prefer bipolar resection. I think you can get better preservation of the tissue, and that's been demonstrated in the literature. You can use other aids such as NBI or blue light as an option to aid in the resection, although that's certainly not absolute. And manual suprapubic pressure is key in any resection to really manipulate the tumor in the bladder wall. So partial distension of the bladder can avoid wall thinning and risk of perforation. These are just sort of pearls of TURBT. Certainly beware of thinner bladder wall, especially in women and elderly women. And when we think about TURBT, it's an aggressive complete resection. You want to resect all visible tumor, and it's a deep resection into the muscular wall, and sometimes in spots down to fat. You may resect into the bladder neck and the prostatic urethra if needed. And you may resect the ureteral orifice. And if you do resect the ureteral orifice, I would advise you to leave a stent through chemoradiation. Always perform a repeat TURBT in cases of muscle invasive bladder cancer that have been resected elsewhere. You need to be comfortable that all of the tumor is resected, and you need to be comfortable that there's nothing that's remaining. Infiltrate any associated field change. So after chemo RT, we then assess the site cystoscopically with a biopsy, and it's a transurethral resection biopsy to assess the muscle underneath the mucosa. This is your opportunity to really assure that there's no residual disease, and I don't always re-resect the entire site. I'd like to welcome my colleague and introduce Dr. Jason Efstathiou, who now will take over and speak about how we move forward with chemoradiation. Dr. Efstathiou, thank you very much.
Great. Thanks, Adam, and thank you to the AUA for organizing this wonderful course. Just getting control of the slides here. There we go. All right. Well, Adam has really kicked this off really well, and I now just wanted to kind of describe kind of the paradigm for chemoradiation. There are many ways that chemoradiation can be done. Certainly, it starts with a maximal TURBT, as Dr. Feldman has very nicely described. And you can do split course radiation, you can do single course radiation. I would argue that more and more these days, we are doing single course radiation, not BID radiation with a treatment break, but single course radiation to full dose, which is typically in the 55 to 65 gray range. Following completion of that, a cystoscopic reassessment of treatment response with a repeat biopsy. If the patient is a complete responder, they go on to lifelong cystoscopic surveillance. And if ever there's a muscle invasive recurrence in the future, a prompt and early cystectomy is recommended. If, however, they are not a complete responder, they may be coming to a salvage cystectomy earlier. And so this is sort of the general paradigm. And as you can see, the U's represent the urologist, and the R and the M represents the radiation oncologist and medical oncologist. My point of putting them on this slide is to highlight that the urologist remains the quarterback of bladder preservation, involved at multiple stages: the maximal TOR, the cystoscopic treatment assessment response, lifelong cystoscopic surveillance, and in about 10 to 15% of patients, the need for a salvage cystectomy. The approach of bladder conservation has really evolved over the years and over the decades. And, you know, really nowadays we have been playing with more enhanced radiation sensitization with different concurrent chemotherapy regimens. We've also looked at issues of adding adjuvant chemotherapy. There's also interest in neoadjuvant chemotherapy. And really nowadays in 2021, there's the evaluation of the role of immunotherapy with chemoradiation, which we'll get back to later in this course. I'm just going to show some of the longer term results from our institution here at MGH, which mirror very much what's been seen in the cooperative group experience. But this is an experience that dates back a number of decades. And in approximately 500 patients with long-term follow-up, you can see a few things. One, at MGH, about 2/3 of our patients have had clinical T2 disease, while 1/3 of patients have had more advanced T-stage disease. There is some hydronephrosis and some tumor-associated carcinoma in situ that is represented in the series as well. A visibly complete TURBT has been achieved by our excellent urologic surgeons 70% of the time. That again is dating back to the 1980s. If you look at more contemporary numbers, that rate is quite a bit higher. And again, dating back over the decades, our complete response to chemoradiation has been about 75%. Again, you'll see on this slide here that rate has really been improving over time. Nowadays, we expect complete response rates to chemoradiation of about 85 to 90% of the time. Part of that, yes, is due to better selection of patients or choosing, quote unquote, the more ideal patients for chemoradiation, T2s, less hydro, more complete TURBTs being performed. And also part of that, I would argue, is that the chemotherapy and the radiation therapy have gotten better over time. These are just curves showing our overall and disease-specific survival rates that represent the entire cohort, again, going back decades. And you can see the 5 and 10-year disease-specific survival rates in the 60 to 66% range. If you look at just T2s, those 5 and 10-year disease-specific survival rates are better than the more advanced tumors, as you would expect. I mean, you would see similar improved results in T2 versus T3, T4 in surgical series as well. And if you look at our contemporary results, this is really important. The 5-year disease-specific survival rate, if you look at patients treated since 2005 at MGH, is about 84%. And yes, those are generally selected populations, but this would compare favorably, I think, to even very select favorable surgical cystectomy series. In addition, our need for salvage cystectomy has plummeted over the years and the decades. Nowadays, I think you can expect salvage cystectomy rates that being needed about 10 to 15% of the time. We'll get more to that. Dr. Feldman will address that further in the course as well. Yeah, patient selection is important, certainly. Here are the factors that are associated with better outcomes. T stage, a complete response to chemoradiation, the lack of hydronephrosis, the lack of CIS, and the ability to achieve a complete TURBT are all factors associated with improved survival outcomes. And that's important to know. So the ideal patient would have these features. That doesn't mean you can't do chemoradiation in patients that don't have all of them. It just means you have to counsel and adjust your expectations based on these types of factors. And of course, similar types of things would apply to surgical counseling as well. We all know when comparing radiation to surgical series, there are issues in comparing that. One is the issue of selection. The other is that there's clinical pathologic stage discordance and T-stage discrepancy. So we know that about 46% of the time, a clinical T2 will be upstaged at time of cystectomy. So that has to be accounted for as well. If we look at, big radical cystectomy series, again, I would argue that most of the patients that have been going for chemoradiation are represented on this orange and green line. And again, you can see long-term disease-specific survival rates in the 60 to 66% range, very similar to what we've seen after chemoradiation series. This is just another big series from USC and the University of Bern, again showing similar kind of disease-specific survival rates over the years. Here on this next slide, you'll see there's a host of population-based studies out there, but real caution is needed in interpreting this. I'm showing here one example that suggested that radical cystectomy is better than tri-modality therapy in terms of overall cancer-specific survival. But if you actually look at the details of the study, patients unfit for surgery were not excluded. And of course, those are the ones getting radiation-based therapy. The median number of radiation fractions was 18, while in the US, we typically would need more than 30 fractions to be considered definitive therapy. There's just a lot of confounding misclassification and selection bias that goes into studies such as this. I mean, similarly, we can look at other large databases, such as from the VA, the Veterans Affairs, and here, they had more stringent definitions. Tri-modal therapy had to have, NCCN guideline approved radio-sensitizing chemo with it. And in series like this from the VA, you can see very similar outcomes between tri-modal therapy and radical cystectomy. The best comparative data probably comes from Toronto, where they instituted a bladder cancer multidisciplinary clinic back in 2008, and patients went for either surgery or tri-modal therapy, and they did propensity score matching, trying to match for all known variables that might affect outcomes. And as you can see here, with good longer-term follow-up, there was no difference between overall survival or disease-specific survival between TMT and radical cystectomy cohorts. I would argue that short of a randomized trial, which unfortunately we don't have, there was a trial attempted in the UK called the SPARE trial that was unsuccessful in accruing. So short of that, I would argue that this is probably the best data. We're currently updating this data with our MGH cohort and other large surgical series from USC and doing large further similar comparative data. some will say, well, what if there's a urothelial carcinoma, but with squamous differentiation? Does that fare differently with tri-modality therapy? And the answer is, at least from data from our institution, that doesn't really change survival outcomes. That being said, I would say most of this was squamous differentiation. So, urothelial carcinoma with squamous differentiation compared to pure urothelial carcinoma. There were some patients represented in this series with micropapillary disease and other higher grade disease. I would say that there wasn't much representation of small cell, for example. So it doesn't necessarily apply to all histologic variants, but certainly those with squamous differentiation, I don't think we see different outcomes. As we saw already from Dr. Feldman, cystectomy is not being performed in about 50% of patients nationally. The age of diagnosis is typically early 70s, and about 50% of patients over the age of 70 with muscle invasive disease are not getting a cystectomy. So it's a huge unmet need, and tri-modality therapy can fill this gap. And currently, while I really sense nationally that there's increasing acceptance and utilization of tri-modality therapy, we can still do better. What about age? Well, we've stratified our results by less than 75 versus greater than 75. And long story short, both the younger and the older populations seem to do equally well with chemoradiation. So you can offer this even to the elderly, certainly. Tri-modality therapy remains a good option. On this slide, I just wanted to highlight some of the real advances that have been happening with radiation. Again, I mentioned this earlier. I think most of us are doing daily radiation, not BID. Most of us have omitted that mid-treatment break, okay, for cystoscopic evaluation, and instead we've gone to full dose chemoradiation and then the cystoscopic reevaluation. There's a lot of debate about the field of radiation. Should we treat the pelvic nodes or not? Is bladder only radiation okay, as has been done in the UK, or can we even focus our radiation to a smaller field and just treat the area of the tumor? What about when incorporating immunotherapy? In radiation, there's always the question, do we treat the tumor in the bladder when the bladder is empty or the bladder is full? These are areas of ongoing debate. And then, there's the option of hyperfractionated radiation. There's some data that's emerged suggesting that 55 gray and 20 fractions is non-inferior to the more conventional 64 gray and 32 fractions. And so a moderate hyperfractionated dose is another option. Though I would say that data really applies to when you're only treating the bladder alone, and certainly doesn't apply to when you're adding immunotherapy. Radiation technologies have advanced. We use now image-guided radiation. That becomes an option, and that might even facilitate increasing the tumor dose, so allowing for dose escalation. On the bottom right-hand panel, you see some images of variable bladder filling depending on the day and how full the bladder was. And obviously, one has to adjust the radiation to that. So there's really a lot of work happening in that area of image-guided radiation. And so with that, I would like to pass the baton on to our medical oncology colleague, Dr. Rick Lee, to discuss chemotherapy.
Terrific. Thanks so much for the introduction, and thank you to the AUA and to my co-faculty for this terrific educational course. So it's my pleasure to talk about chemotherapy and its role in this treatment modality. Just taking control. So I'll just start by saying that concurrent chemotherapy is really important to the success of TMT. It's really important, and it's very rare that a patient cannot actually get chemo with radiation therapy. So even as Dr. Stathio was describing, the elderly patients, the frail patients, they can still be candidates to receive chemotherapy along with the radiation. There are a few roles for chemotherapy with TMT that I'm going to discuss. They include the concurrent use of chemotherapy, a role for adjuvant chemotherapy, and then neoadjuvant chemotherapy. I'll say that there are a number of active radiosensitizing drugs. They are listed here: cisplatin, paclitaxel. You'll see a lot of use of 5-FU and mitomycin C, as well as gemcitabine. The last is the carbogen nicotinamide, a combination of vitamin B3 and carbon dioxide and oxygen as hypoxia modifiers. But when we consider which chemotherapy agent should we choose, this is just a single institution experience that just highlights that there's the benefit of adding chemotherapy along with radiation. As you can see here, the complete response rate on the right for radiation therapy alone is 57%. And this sort of hints at the idea that adding carboplatin and then cisplatin and then the combination of 5-FU and cisplatin are associated with higher rates of complete response along with radiation. So for this portion of the talk, I'm going to cover a few highlighted studies that really sort of get us to our current standards. These include the BC 2001 study, several RTOG studies, and the University of Michigan studies, and I'm going to cover these in greater detail. So first, looking at the BC 2001 study, this is a phase 3 chemoradiation versus radiation study in muscle invasive bladder cancer. It had 360 patients. It was published in 2012. In this case, patients received radiation with or without the chemotherapy mitomycin C and 5-FU. Important to note here that the median follow-up was 69.9 months. The mitomycin C and the 5-FU, the doses are provided, as you can see. I guess one potential disadvantage is the requirement for a portacath. The primary endpoint was survival free of local regional disease, with secondary endpoints of overall survival and toxicity. This next slide looks at the overall survival. So if you look at chemoradiotherapy as compared to the radiotherapy alone, in the blue curve is chemoradiation, and you can see that there may be some improvement in overall survival. I failed to mention that 32.8% of the patients also received neoadjuvant chemotherapy, and we'll get back to that later. So overall survival generally looks similar, but if you look at the other the primary endpoints of really survival-free of local regional disease. So these slides look at disease-free survival. So local regional disease-free on the left and invasive local regional disease-free on the right. And again, chemoradiotherapy is in blue and radiation therapy is in red. And you can see that the curves quite clearly separate, indicating a benefit to chemotherapy concurrent with radiation. Turning to the RTOG 0233 study, this is a randomized phase 2 study that looked at patients, 93 patients, and they were randomized to receive twice daily radiation in either 5-FU and cisplatin or paclitaxel and cisplatin. So the regimen with 5-FU and cisplatin requires the use of a portacath because of the continuous infusion 5-FU, whereas the paclitaxel cisplatin regimen does not. And all of these patients received adjuvant chemotherapy. The primary endpoints of this trial were the rate of treatment completion and tolerability. And what you can see is that in terms of the overall survival, which is this next slide, you can see that the patients in the paclitaxel group in red and the 5-FU group in blue, the overall survival curves were overlapping. And if you look at survival with an intact bladder, so ability to maintain their bladders, these curves are also overlapping, suggesting that either one of these chemoradiation regimens is reasonable to choose. These tables covered the adverse events, and I will just highlight for you that in the boxes are grade 3 and grade 4 events. And these really indicate that the toxicity between the two arms is really quite comparable and really quite low. Turning next to our use of gemcitabine as a radiation sensitizer, it really is born from these University of Michigan studies that looked at these phase 1 studies that looked at daily radiation, so not twice daily radiation, but daily radiation, but twice weekly gemcitabine. And here they looked at 23 evaluable patients. This is a phase 1 study, again, to find the optimal dose. All patients received radiation, and then they received twice weekly gemcitabine. At a median follow-up of 5.6 years, here you can see the number of different gemcitabine doses that were used. And there were a number of dose-limiting toxicities that occurred at 30 and 33 mg per meter squared. So 27 milligrams per meter squared became the maximum tolerated dose. And here you can see in these curves, these look at the efficacy of this chemoradiation strategy in terms of disease specific survival and overall survival, as well as ability to maintain an intact bladder. Based on the prior studies I just described to you, the RTOG then embarked on a randomized phase 2 study looking at patients getting either the Michigan-style daily radiation with twice weekly gemcitabine or the RTOG twice daily radiation with 5-FU and cisplatin. And so you can again see that the twice daily radiation is a little bit more intensive in terms of coordination of care. Patients would need a portacath. The Michigan regimen does not incorporate a treatment break. It's definitive radiation. It does not need a port. And all patients were meant to receive the adjuvant chemotherapy. And the idea here was that if either arm has at least 75% distant metastasis-free survival at 3 years, then that treatment would appear to be promising. So this is the primary endpoint for the RTOG study was distant metastasis-free survival. This is reported a median follow-up of 5.1 years. And I think you can see here that metastasis-free survival was really very similar between the two groups, getting the twice daily radiation with 5-FU and cisplatin or the daily radiation with gemcitabine at 78% and 84%. So really quite similar. When they looked at the toxicity, which is the next slide, I think what you can take away from this slide, again, 5-FU cisplatin on the left and gemcitabine daily radiation on the right. The takeaway here is that the toxicity was that both regimens were really, really quite well tolerated. Looking at the complete response rate, what you can see here in the complete response row, that both regimens had a high complete response rate, 88% and 76%. And then if you look at the bladder intact distant metastasis-free survival, so patients who've maintained their bladder, that what you can see is that the bladder preservation rates of 67%, and I'm circling them here, 67% for the 5-FU cisplatin and 72% for the gemcitabine regimen were both high and looked equivalent. So I think what this study really showed us is that gemcitabine is a reasonable alternative to cisplatin and 5-FU, especially with patients who have renal function that precludes the use of cisplatin, or if they have hearing loss that precludes the use of cisplatin. This really also pointed us that daily radiation is also really quite reasonable and hopefully can allow for wider adoption of tri-modality therapy. So what about the value of adjuvant chemotherapy? I've just described to you various regimens for concurrent chemotherapy. So what's the value of adjuvant chemotherapy? And there really is no level 1 evidence for adjuvant chemotherapy post-cystectomy. We have evaluated a number of trials that have been run through the RTOG, NRG, and at MGH. And the adjuvant chemotherapy is associated with disease-specific survival only on univariate analyses. What about neoadjuvant chemotherapy? And one of the early RTOG studies was 8903. These are patients, 123 patients who received 2 cycles of MCV, methotrexate, cisplatin, vinblastine, neoadjuvant chemotherapy, and then received radiation with cisplatin as the radiation sensitizer. And the real result here was that there was no difference in overall survival or disease-free survival, metastasis-free survival with neoadjuvant chemotherapy. So this was not further pursued. When we look at our data in aggregate with other, in terms of other trials, our data for neoadjuvant chemotherapy, these are the red curves, patients who received neoadjuvant chemotherapy compared with the blue curve, patients who did not receive neoadjuvant chemotherapy, really showed overlapping and therefore similar results in terms of overall survival, disease-free survival, and then the cumulative incidence of distant metastasis. And I think this is really quite consistent with other large studies that included neoadjuvant chemotherapy that didn't show a clear benefit, including the BC 2001 study. And this is going to be my final slide that will just describe, so what do we do in practice? How do we incorporate all of this information that I've been describing to you? And I would say that in general, we don't use neoadjuvant chemotherapy for patients with tri-modality therapy. I think as we've done for on a case-by-case basis, there are some patients who've had bulky lymphadenopathy where we've first given neoadjuvant chemotherapy and seen a disease response for the lymph nodes, and then moved on to tri-modality therapy. So that is a circumstance that we've certainly considered neoadjuvant chemotherapy. For patients who are cystectomy candidates, if they're cisplatin eligible, one regimen may be the twice daily radiation cisplatin 5-FU. Of course, as I've described, this is an intensive treatment that requires close coordination between our urologists, radiation oncologists, and medical oncologists. And so for some, that's not a very feasible approach. But for patients who are cisplatin ineligible or don't want the twice daily radiation, then the regimens that we consider are daily radiation, the definitive course of daily radiation with 5-FU mitomycin C, or the twice weekly gemcitabine. Now, for patients who are not cystectomy candidates, if a portocath is reasonable for them, then we'll go with the daily radiation and 5-FU mitomycin C. But if not, then we'll go with the daily radiation and twice weekly gemcitabine. So with that, I'll conclude this portion. And move on to Dr. Feldman.
Wonderful. Rick, thank you so much. That was outstanding. Just going to get control of the slides here. Try that again. There we go. So surveillance after tri-modality therapy, and I should say surveillance after chemoradiation is critical. And it's really, where the urologist continues to have a very important role in management of these patients. On the right-hand side of the screen, you can just see an image of a scar, and this is a video just of a patient's bladder after tri-modality therapy. I have noted at the second bullet point that at 17 weeks post-consolidation, cystoscopy and biopsy is performed under anesthesia. I'll just clarify that as Dr. Stathiou commented, that really most of our patients now go straight through a single course, and we then perform cystoscopy and a TUR biopsy really at 2 to 3 months. Expect that there's going to be some persistent eschar and ulceration at the tumor site that we know. You may see some mild radiation change that is highlighted on the video. What you do is when you assess these patients, you want to debride the fibrinous tissue with the cold loop and then biopsy the viable muscularis in the bladder wall. Historically, we had done an additional cystoscopy and biopsy at 3 months and then convert to office cystoscopy after the second negative biopsy. I would just say that I think most people who do a lot of this, and including us, we've often omitted that second biopsy if the initial biopsy is negative and there's no evidence of any disease after that. So the surveillance schedule is really similar to high-risk non-muscle invasive bladder cancer. It's every 3 to 4 months in the first 2 years, every 6 months until 5 years, and then annually for life. These patients are always at risk, and always important also not to forget the upper tracts when doing CT scans. So in patients who have renal function to accept IV contrast, we do try to get CT urograms to assess the upper tracts, again, just as you would in somebody with high risk non-muscle invasive bladder cancer. And we use voided urine cytology as well. So what about radiation cystitis? People always ask about that. The majority really are clinically insignificant. There is the occasional need for intervention. Out of 500 patients in our experience, 2 have needed cystectomy for end-stage bladder. So really most patients do quite well. Now, how about managing local recurrence? And let's start with the risk of local recurrences. So the risk of local recurrence at 10 years, this is a pooled analysis from the RTOG published in 2014. And at 10 years, the risk of local recurrence was 36% of the 36% risk of non-muscle invasive bladder cancer recurrences, and a 14% of the patients had a muscle invasive recurrence. What about some individual centers in their experience? These are our experiences. These are a little earlier in our experiences published in 2001, and patients who had achieved a complete response. 26% had non-muscle invasive recurrences, and 13% had an invasive recurrence. And what we found, if you look at the table in the upper right-hand corner, is that about 60% of these non-muscle invasive recurrences were carcinoma in situ, and 28% were T1. And the median time to recurrence was 2.1 years. The experience in Germany was similar. Interestingly, they're complete responders. Their risk of a muscle invasive relapse was 17%, and the risk of a non-muscle invasive recurrence was 17%. And their median time to a non-muscle invasive recurrence was 1.3 years. Interestingly, there's just a little bit of a typo here. Of the 323 patients who did not have a muscle invasive relapse, in other words, the had the bladder relapse, no bladder relapse, or superficial relapse. Interestingly, 37% of those original tumors were T1, and 41% were low grade. And so this group is a little bit different than our group and those in the RTOG, in that they did treat patients who had low grade and T1 disease initially. And that may also contribute to the lower non-muscle invasive relapse rate. At Princess Margaret Hospital, also there was somewhat similar local relapse rates of 26% for invasive disease, 16% for non-muscle invasive. And interestingly, what they found was that the local recurrence rate was greater with larger tumors, so tumors that were over 2 centimeters, and also those with associated carcinoma in situ. And sorry, in the title that CIS was cut off mistakenly, but it's really, it was greater in those with patients who had larger tumors and those with associated CIS. So how do we treat those recurrences? These are our data that were published a few years back. Again, we saw that there was 25% of patients had non-muscle invasive bladder cancer recurrences. And we also, similar to the Princess Margaret experience, showed that in the primary tumor, if there was CIS, there was a higher risk of having a local recurrence. And that goes along with what we know about non-muscle invasive disease. 8 of those patients had immediate cystectomy. And of those who had TURBT, 12% ultimately progressed to muscle invasive disease. 24% ultimately ended up having a salvage cystectomy. How did we treat them? 39 patients had BCG post-TURBT. 74% of those patients completed BCG induction. So really, the majority of patients completed BCG induction. 36% received maintenance BCG. 49% reported some level of BCG toxicity. And at 3 years, the recurrence-free survival was 59%, and the progression-free survival was 63%. And what we can see is that those patients who had no recurrence overall, those patients who had no recurrence versus those who had a non-muscle invasive recurrence had really similar overall survival, but slightly lower disease-specific survival in the those who had a recurrence. So what are the take-home messages for non-invasive recurrences? Most non-invasive recurrences can be managed similarly to de novo non-muscle invasive bladder cancer, and most patients tolerate intravesical therapies really quite well. However, patients who have T1 disease, larger tumors, carcinoma in situ, or LVI, they can be managed as non-muscle invasive disease, but you really do want to discuss the option of salvage cystectomy up front, and that should certainly be discussed as an option with patients. So what about those who need a salvage cystectomy and have a muscle invasive bladder cancer recurrence? This is just data that Dr. Stathu had discussed. These are our experience, and the overall need for salvage cystectomy was 29% at 5 years and 31% at 10 years. And at 5 and 10 years survival, 5 and 10 years survival after salvage cystectomy for recurrent disease was 64 and 55%. So not too different than de novo disease. And the salvage cystectomy rates in our series really are very similar to those seen in other series. And in the Toronto series here, we see that the rate is about 10.7% risk of needing a salvage cystectomy. And then also we see similar rates as well in other series. One of our prior residents had done a pooled analysis of the RTOG studies looking at salvage cystectomy. And here you can see the disease-specific survival in patients who underwent salvage cystectomy. And that really you can see it's very similar, the outcome and the disease-specific survival outcome in those who had a salvage cystectomy is similar to those who have de novo invasive disease. So what about the morbidity of a salvage radical cystectomy? This is a question that people always ask in those who've had tri-modality therapy and chemoradiation. This is our experience, which was published a little under 10 years ago, and we've recently updated, which I'll get to. All patients had cutaneous diversions. 3 out of 91 patients did have a rectal injury, so that rate of intraop rectal injury, which we all worry about, is really quite low. Only one of those patients had a colostomy. At 90 days, there was a 69% risk of any complication and a 16% risk of a major complication. And when we compare that to a large series from Memorial Sloan Kettering, you can see that the overall complication rate, again, 69% salvage cystectomy compared to the de novo cystectomy series, 64%, and then the major complication rate of 16% versus 13%. And it's not that different, but there's maybe a slight difference there. Interestingly, when we look at those who went on to need an immediate cystectomy, in other words, they failed immediately, didn't have a complete response, they actually had a higher risk of a cardiovascular or hematologic complications, and maybe that's the recent chemotherapy that they had, compared to those who then had a delayed cystectomy later on in follow-up. They actually ended up having tissue healing, more likely to have a wound or anastomosis or stoma complications, and maybe possibly because of the higher radiation dose that they ultimately received. We recently updated this experience and compared patients who underwent a salvage cystectomy post-TMT versus those that underwent a primary cystectomy for muscle invasive disease and had no history of radiation. And a third arm, those patients who had a cystectomy after other pelvic radiation, whether it's prostate cancer or rectal cancer or other. There was no difference in intraoperative or early complications, but there was a higher risk of late complications, including infectious GU and GI complications. And you can see that in the Kaplan-Meier curve here with primary cystectomy in blue and then the salvage cystectomy in red. Interestingly, in terms of disease-specific survival, there was no difference between the 3 groups, and overall survival, there was no difference between the 3 groups. So in summary, for salvage cystectomy, we know that there's a slightly higher complication rate, really minimally, I would say minimally higher. Therapy is, salvage cystectomy is usually followed by ileal conduit or continent cutaneous reservoir, and a neobladder is not impossible, but it certainly has a higher risk of having urethral anastomotic stricture and incontinence. So speaking of that, I believe now we're going to be getting back. I've lost slide control, and we'll get back to Dr. Stathu to talk about quality of life and biomarkers.
Great. Thank you, Adam. That was excellent. And I'm just getting slide control here. There we go. All right. So we've so far addressed a lot of different aspects surrounding tri-modality therapy. And of course, you know, why spare the bladder unless it has some potential quality of life benefits, of course. And so that's what we're going to pivot to now and look at a little bit. In general, experiences suggest that tri-modality therapy has acceptable toxicity, and quality of life after bladder preservation is pretty good. The question is, how often are serious things happening, such as hemorrhagic cystitis or contracted bladders, causing very poor bladder function after radiation therapy, or things like that. And so, what we can look at are some large trial experiences, including from the RTOG, NRG Oncology, and also from the UK from trials such as BC 2001. And in general, if you look at significant toxicity, grade 3 or higher, those rates are all under 10% and usually low single digit range, as you can see here from the NRG RTOG trials and also from BC 2001, a mixture of mostly, it tends to be more GU, but also some GI toxicity. But again, it's thought to be relatively low rates and overall acceptable toxicity. Our colleague, Dr. Zeitman, had done some, with urologic colleagues at MGH, had done urodynamic studies and quality of life studies. This is about 20 years ago, suggesting that bladders, 80% of the time were compliant with normal capacity and flow parameters. 85% of patients after chemoradiation had no or only occasional urgency issues. About a quarter of patients had occasional to moderate bowel control symptoms, and 50% of men had normal erectile function after chemoradiation. Certainly the way we design radiation and radiation technologies have changed drastically, and I do feel that bowel issues and complications are less these days. The erectile side of things is interesting, and we'll get a little bit more to that shortly as well. This year was a study done by the folks from Germany in Erlangen, and they asked patients who'd gone through tri-modality therapy, if you were to spend the rest of your life with your urinary condition the way it is now, how would you feel about that? And as you can see here, about 90% of patients were mostly satisfied to delighted. And so urinary symptoms seem to be, in general, okay for the majority of patients. In general, there's little data comparing quality of life between cystectomy and tri-modality therapy. Again, that randomized trial, the SPARE trial, closed early due to poor accrual. And obviously, both treatments can have effects. There are some cross-sectional studies, such as this one from Sweden. Again, urinary function after radiation, 74% of patients had no or little urinary symptom distress, very similar to the MGH data that I just showed. A little more bowel function issues after radiation compared to cystectomy. But here again, the sexual function side of things, after radiation, 38% of patients had intercourse in the last month, compared to only 13% after cystectomy. And study after study, I think, are pretty consistent that sexual function after chemoradiation tends to be better than after cystectomy. Here's a systematic review of 6 quality of life studies. And again, generally suggesting excuse me, that tri-modality therapy is associated with good general quality of life, satisfactory urinary function, and satisfactory sexual function, though there's likely more bowel symptoms than after cystectomy. In general, these are limited studies. We tried to do a more detailed study, and we paired up with the University of North Carolina and looked at longer-term quality of life in long-term survivors after either chemoradiation or cystectomy. And this was a cross-sectional study. They had to be disease-free for at least 2 years, and the median follow-up was long. 63% of the patients in this cohort had received a cystectomy. Most had an ileal conduit, but about close to 20% had neobladders. Again, this is a bit of an older study. And 37% of the patients had received tri-modality therapy, of whom 9% required salvage cystectomy, which is very consistent with the contemporary rates of salvage cystectomy. Again, about 10%, 10 to 15% in the MGH contemporary data and in those other studies that Dr. Feldman showed you. We use 6 validated quality of life questionnaires, so a battery of questionnaires that were also bladder specific. They're listed here. These are the instruments that were used. Each instrument was scaled on a score of 0 to 100. And in general, both cystectomy and tri-modality therapy were associated with good long-term quality of life outcomes. But when compared to radical cystectomy, tri-modality therapy seemed to be associated with modestly higher general quality of life scores, similar urinary scores. Well, why isn't it better if you spare the bladder? Well, frankly, you might have some irritative symptoms after radiation-based therapy. And on the flip side, patients tend to accommodate and adapt to urinary diversions actually quite well, and don't have those urinary irritative bladder symptoms. So I guess if you think about it, not surprising. Markedly better sexual quality of life with TMT again, study after study seeing that. Better informed decision-making, less concerns about appearance, less life interference from cancer or cancer treatment. So those were some significant findings that came out of this study comparing tri-modality therapy to cystectomy. But again, all of these studies are limited, right? They're retrospective and limited in a number of ways. Because unfortunately, again, we don't have a prospective comparative randomized trial. Decision analyses have been performed using Markov modeling, looking at quality adjusted life years, again, suggesting that in general, there is, if you take, for example, a favorable TMT cohort, this is the small T2s that were completely resected, et cetera, and comparing them to a favorable radical cystectomy cohort, again, small T2s, there appears to be an incremental gain in QALYs of about 1.6 years. Again, this is limited data. It's only as good as the data that informs the model, of course, but all consistent that there may be some quality of life advantage to tri-modality therapy. In the remaining time, I'm going to address biomarkers and the emergence of immunotherapy and what it means for tri-modality therapy and some future directions. And once we wrap up this section, we're going to have plenty of time for some cases, questions, etc. So we've been addressing a lot of clinical pathologic factors so far that impact decisions surrounding tri-modality therapy. Some of them are listed here. But the question is, can genomic factors inform bladder-sparing therapy? What's up with biomarkers? And the hope would be that there we go. The hope would be that we can move towards biomarker-driven management of muscle-invasive disease. That biomarkers are used in a multidisciplinary fashion to help with clinical decision-making. Are there some biomarkers that might help us choose which treatment a patient would be best served by? Are there liquid biopsy biomarkers that could be used for surveillance in follow-up? I'm going to just pause here as I see from the chat that there's a question that's come in regarding, is there any difference in quality of life outcomes between males and females? Phenomenal question, whoever has asked that. And actually, we have a wonderful analysis led by Leslie Ballas from USC that is a paper that was just recently accepted or working its way through the journals. That has looked exactly at this issue. And there may be some differences in terms of bowel function and sexual function between males and females. And so we look forward to the reporting of that study. So please do look out for that. So I'm going to come back here to biomarker-driven management and the question, are there biomarkers we can use? What's going on in this world? And here is a table that lists selected biomarkers that have been evaluated with bladder preservation therapy and their references. You can see they fall into the usual sort of categories: DNA repair genes, immune checkpoint markers, molecular signatures. And we're going to look a little bit more at some of these. For example, there's a protein called MRE11 that's part of the mRNA complex involved in double-strand break DNA repair. And there was some suggestion from a UK group and also from a a study from Denmark. And in these retrospective cohorts, MRE11 expression seemed to predict disease-specific survival in response to bladder preservation strategies, right? Here, high MRE11 expression did better after radiation-based therapy, but not after surgery. Well, there is the inkling of a possible predictive biomarker. We have looked at this in NRG, RTOG studies, and certainly, again, this has not been comparative to cystectomy, but within chemoradiation series, MRE11 appears to be prognostic for disease-specific survival. So those that are high expressors, the blue line, fail less, okay, than those that are low expressors. So more work is needed on MRE11 as well. And of course, all of these biomarkers need prospective validation. There's been some subtyping as well of tumors. Of course, subtyping of tumors by expression profiling has been all the rage in bladder cancer. Very broadly, bladder cancers can be broken into basal subtypes or luminal subtypes. And there's been some suggestion that subtyping predicts the benefit of hypoxia targeting therapy. In the UK, instead of concurrent chemotherapy, some studies have looked at concurrent carbagin and nicotinamide, which are hypoxia modifying drugs. And look at this, very similar to the data looking at neoadjuvant chemotherapy before cystectomy, that there's a difference in the basal subtype, but not in the luminal subtype. Right. So again, for example, with surgery, maybe you don't need neoadjuvant chemotherapy in luminal subtype tumors, but you definitely should be using them in basal subtype tumors. I'm not offering clinical advice here. I'm just saying how the biomarker field might be playing out. Similarly, it might affect choice of concurrent therapy with radiation. We've looked at expression subtypes and we have identified them in muscle invasive bladder cohorts that are treated with tri-modality therapy as well. And, there is lots of evidence that radiation can influence the immune microenvironment. And because of this complex relationship, in this study here, we decided to test whether the immune microenvironment affects radiation sensitivity. And one of the key changes, of course, is an increase in T cell infiltration. And hence, that's a signature that we looked at. And what we saw was that immune infiltration signatures, such as that one, were associated with improved outcomes after tri-modality therapy, but not after neoadjuvant chemotherapy and radical cystectomy. You can see the curves are flipped of the colors here. And so this observation that an immune activated subset of patients may have improved outcomes with tri-modality therapy suggests that these patients may derive even greater benefit from the addition of things like immunotherapy, of course. So, there's some real interesting work that's going on. And of course, there is a lot of data that looks at the synergistic effects of combining immunotherapy with radiation. Hint for those questions, one of the questions that Dr. Feltman was showing at the beginning of the course, there has been, a transformative impact of immune checkpoint blockade in the treatment of advanced and metastatic disease, first line maintenance, second line bladder cancer in the advanced and metastatic settings. But it's also become the focus of numerous contemporary studies in localized disease. And in fact, as everyone knows, it's been FDA approved, Pembro has, for BCG unresponsive high-risk non-muscle invasive disease with CIS. To date, to our knowledge, there's no FDA approval in the muscle invasive bladder cancer setting, but lots of trials going on perioperative, and certainly also lots of trials looking at it with tri-modality therapy, chemoradiation. So hopefully more approvals to come if those studies pan out. Whoop, sorry. Yeah, so coming back to this sort of complex interplay between the immune system and radiation and the potential for a synergistic effect. This is a complicated topic, actually, because the interplay between radiation and the host anti-tumor immune response is multifactorial and heterogeneous. Radiation can exert immune activating effects like listed here via a variety of methods. Conversely, radiation also has immune suppressive effects, and a number of those effects are listed there as well. So immune checkpoint blockade therapy, immunotherapy, may actually provide an opportunity to tip this balance by attenuating radiation-induced immunosuppressive effects while preserving radiation-induced immune activation, and thus leading to a synergistic anti-tumor immune response. So that's kind of what goes behind this, but there's a very, very complicated relationship between radiation and the immune environment. Certainly there's preclinical data as listed here showing synergistic effects when you add radiation with immunotherapy. You get a better effect with both than either one alone. There's also lots of interesting data looking at the impact of timing of radiation immunotherapy. And in general, a summary of that data would suggest that concurrent delivery of radiation with immunotherapy is better than sequential. I would say in general, most of the studies would show that. And so, the rationale for combining immunotherapy with concurrent chemoradiation seems to be pretty strong. Lots of preclinical data. Radiation is upregulating the expression of PD-L1 in tumor cells in a dose-dependent fashion. Concurrent radiation and PD-1 inhibitor shows augmented responses in mouse models. Combined chemotherapy and PD-1 inhibitor is already approved treatment in other diseases such as lung cancer. And there's a host of trials that are going on looking at chemoradiation with immunotherapy in localized muscle invasive disease in the phase 1, phase 2, and phase 3 settings. And so why don't we look at some of those trials a little bit. Here I've just, taken a slide from one of our medical oncology colleagues that shows some select ongoing phase 2 trials. And there's one study that was recently reported at Astro called the Duart study. There's also this study here run out of NYU and a few other centers looking at pembro and gemcitabine and hyperfractionated radiation. I'm aware that this study will report early preliminary findings at the upcoming ASCO meeting. So lots of these sort of phase 2 studies, phase 1, phase 2 studies are starting to report. But if we look at one that's actually been presented, the Duart study, look at this, overall good response rates and good disease control rates when using concurrent and adjuvant durvalumab. And again, just to go back here, just to tell you what the patient population was, this was a cis-ineligible, unresectable, unfit for surgery, locally advanced or node positive. So this was advanced bad disease. Good response rates, good disease control, also at 1 year. And there were overall clinically significant immune-related adverse events were pretty minimal. And the GI-GU grade 3 toxicity was under 5%, very consistent to what I was showing earlier in terms of the quality of life side of things. So pivoting also to phase 3 trials, there's this trial that we have ongoing. It's an intergroup trial led by SWOG and NRG, 1806 study called the INTACT trial. It's a phase 3 randomized trial, muscle invasive N0 disease. 475 patients is the target accrual, and it's randomized to chemoradiation plus minus 9 cycles of atezolizumab, okay, given both concurrently and adjuvantly. The trial stratifies by chemo regimen. It allows, it's dealer's choice. You can do cis alone, 5-FU mitomycin C, and low-dose gemcitabine. You can choose, and that's just following on all the data that Dr. Rick Lee showed you earlier. You can also choose the radiation field, meaning do you treat the pelvis or not, the pelvic nodes or not. I alluded to that controversy and debate, as to what to do. In general, we do treat pelvic nodes, but not all practices do, and that's totally fine. And this trial is permissive and pragmatic in that regard in allowing all that. In fact, when using immunotherapy, there is some data that suggests that if you treat the pelvic lymph nodes, you may attenuate a little bit of the effect of the immunotherapy, which could make sense. There's some mouse model data that has actually looked at that. So this trial will more importantly inform that question in the clinical setting in a phase 3 setting. Primary endpoint is a patient-centric endpoint of bladder intact, event-free survival. All of the events that compose that endpoint are listed down here. And of course, a host of secondary endpoints that are obvious are being looked at. And there's a lot of translational medicine built into this trial. This accrual is actually slightly outdated in the sense that now we're at over 150 patients on the trial. And I can tell you that this past month of April, we accrued 13 patients. So we're and this is through, of course, COVID, so this trial is doing well. And for a bladder sparing trial, it's doing awesome. Most trials in the bladder sparing space in the past have been on the order of 70 to 90 patients. So one that's going for 475 patients and accruing 10 or more patients a month is certainly doing well and suggests that bladder preservation has gained more acceptance and utilization nationally. We did report at GU ASCO the safety toxicity update on the first 73 patients from this trial. And I can tell you that there was no grade 3 or higher colitis in the atezo arm, and that overall 23 patients experienced grade 3 or higher toxicity events on the atezo arm versus 11 on the non-atezo arm. But the most common toxicity was what you would expect, hematological, anemia, lymphopenia, etc. None of the grade 3 or higher toxicities were considered to be specifically immune related. So I think you're just seeing in this with the Duarte study and other studies suggesting that the combination of immunotherapy with chemoradiation is safe. And now we need to see what some of the efficacy data is going to show over time. There are other phase 3 studies. This study started about a year after the INTECT trial and is very similar in design. It's just using Pembro instead of atezo, pretty much. It also, if I recall, may allow for moderate hyperfractionated radiation. Then there is the CCTG-BL13 study, which is being run in Canada, that is using adjuvant durvalumab. It is not giving it concurrently, although I suggested there is some preclinical data suggesting concurrent administration may be best. We don't know that for sure. And so this is another phase 3 trial looking at the adjuvant delivery of immunotherapy. So when we have all of these studies, the INTACT trial, the Keynote 992 trial, and the CCTG trial, we're going to have a lot of phase 3 data to inform all kinds of nuanced questions. There's also the INSPIRE study, which is a partnership between ECOG, ACKNOWLEDGEMENTS, and NRG, which is a phase 2 trial of chemoradiation plus minus durvalumab in stage 3 disease, so node positive disease. Okay, so there's also a trial in that setting. If you haven't opened these studies, please consider doing so. Lastly, I just want to say that, a word of caution is needed. There are some studies, for example, this was a phase 1 study from the UK called the PLUM study that suggested some dose limiting toxicities when combining pembrolizumab with hyperfractionated radiation. In this case, the hyperfractionation was a little more ultra hyperfractionated. It was 6 gray once a week for 6 weeks. So 36 gray over 6 weeks, but 6 gray in individual fractions. And there was, in fact, a grade 4 bowel perforation. So just a word of caution of incorporating immunotherapy, and why all of that safety data is really important coming out of the large phase 3 trials. There was also this study here recently from Canada, just reported in the Red Journal, suggesting, again, dose-limiting toxicities with a T-zone tri-modality therapy when you're doing it moderately hyperfractionated radiation. Moderately hyperfractionated radiation would be that 55 gray and 20 fractions. That would be a typical moderately hyperfractionated regimen. And in this phase 1 study, again, there was sort of, dose-limiting toxicities that were GI-related, colitis-related. It's for that reason in the intact randomized phase 3 trial that we don't allow moderately hyperfractionated radiation. We're sticking to conventionally fractionated therapy. So in summary, in 2021, patients should be offered tri-modality therapy with muscle-invasive disease because many are not getting curative treatment nationally. There's an undertreated and underserved population. It's being supported by numerous guidelines. As Dr. Feldman showed you, it is a category 1 recommendation per NCCN. In clinically matched patients, survival is comparable to radical cystectomy in the modern era. Remember that Toronto data that I showed you? 85% of contemporary patients keep their own bladder these days, 85 to 90% probably, and long-term quality of life is good and may be better than a cystectomy in a large number of these patients. Tri-modality therapy is not a non-surgical treatment. Dr. Feldman has highlighted that beautifully. A maximal TURBT is an elegant procedure and operation, and a salvage cystectomy, which is going to be needed in 10 to 15% of these patients. Those are really important components of a successful TMT program. There are lots of opportunities to continue to improve the delivery of radiation. I alluded to image guidance, dose escalation, hyperfractionation, field design, and to optimize systemic, concurrent, neoadjuvant, and adjuvant therapies that Dr. Lee got into beautifully, including possibly the addition of immunotherapy. Some of the trials I just went over are looking at to further improve outcomes. There's preclinical rationale for combining radiation immunotherapy and bladder cancer and some clinical evidence in advanced disease and ongoing trials, of course, looking at the role of incorporating IO into TMT, and we saw those studies. And the results of these trials have the potential to alter the treatment paradigm for TMT, and planned correlative studies may provide really some novel mechanistic insight into the determinants of immunotherapy response and how that interacts with radiation. And the validation of some of the biomarkers that I discussed in independent cohorts and in prospective trials is absolutely necessary. Prospective validation is needed to further guide bladder preservation therapy for muscle-invasive disease and for personalized treatment selection. And we need to continue to advocate for multidisciplinary engagement. It's so wonderful. Doctors Feldman and Lee, we've worked over a dozen years together, in a Friday clinic where we see a lot of these patients, and we work hand in hand. The patients are seen concurrently by all 3 disciplines. We really advocate that approach for muscle-invasive bladder cancer patients. And so, at the end of the day, it's safeguarding the autonomy of these patients. Informed decision-making by the patient is key as they are presented valid options and the pros and cons. And so with that, we all thank, a lot of folks that are listed on these slides and many more that are not. Bladder cancer requires multidisciplinary teamwork. We're very fortunate at MGH to have a wonderful big team, but that extends nationally to many other centers and groups. And so we are very grateful for that. And with that, I want to thank again the AUA for the opportunity for us to run this course. I'm going to hand it back to our course leader, Dr. Feldman, to address questions and case discussion.
Great. Thanks, Jason, and thanks, Rick, for really wonderful presentations. We will go forward with talking about some case discussions, and I'll just say to the audience, please put any questions in the chat. We'll be able to see them as they come in, and can address them again as they come in. So in no way please wait until we're done with these case discussions. We're going to wrap up for the post-test questions by 4:45. So please just send your questions. There we are. So case 1 of a localized bladder cancer is a 62-year-old healthy male. First occurrence of bladder cancer. He had clinical T2 high-grade urothelial carcinoma of the bladder. It was a single 4-centimeter tumor on the left posterior wall. He had a complete TUR, according to the local urologist. No mass on exam under anesthesia, no hydronephrosis, no adenopathy, and he had a good renal function. So this is his CT scan. I think you can see my mouse just demonstrates a nice image of the tumor and the bladder. And this is the tumor cystoscopically, and then an image post-TUR. So here we have a nice histologic image. You can see the bands of smooth muscle, the tumor invading, just demonstrating that this was muscle invasive disease and actually had some squamous cell features. So is this a candidate for bladder preservation, and what strategy? So we can talk a little bit about tumor anatomy, and we talked about the tumor sort of characteristics and the patient characteristics, and is this a patient who is a candidate for bladder preservation? And I'll start and comment, and often really it starts with the urologist. We're the ones who are seeing these patients, doing the resection, seeing the tumor in the bladder, really assessing, and then bringing them to the multidisciplinary clinic. And I'm always assessing a patient who, to see, is this a possibility? And so if we think about, what he has, it's a resectable tumor. There's no hydronephrosis. There is not extensive associated CIS. Really, from a tumor standpoint, he is a good candidate. From a patient standpoint, also a good candidate. And so I think what I'll ask my colleagues what the strategy would be.
Yeah, I can quickly comment, Adam. If you go back a couple of slides, maybe one more. Yeah, this is kind of an ideal, right? This would fall into the ideal candidate for bladder preservation. It's a tumor where a complete TUR has complete TURBT has been performed. This is a really favorable location for radiation therapy, by the way. You don't see any small bowel in the field here, right? On this, well, it's a single axial slice, but there isn't. So we can deliver our tumor boost doses well here, because bowel, small bowel in the field draping over the bladder is often one of the limiting factors in radiation field design. So it's sort of ideal that way. If you go to the next slide, it's urothelial carcinoma. It has some squamous cell features, but we saw the data earlier. That doesn't preclude TMT. In fact, these patients do just as well as the pure urothelial patients, right? And then the other factors of the case: good bladder function, good renal function. This is the ideal candidate. And so I would argue, Dr. Feldman's performed the complete TURBT. This should be chemoradiation. Radiation is going to go, to full dose. And I generally, in most cases would treat, limited pelvic nodal field as well. And Dr. Lee maybe can now comment on his choice of systemic therapy.
Yeah, we'd often wind up using something like 5-FU and mitomycin C for patients like this, especially if we're using definitive radiation, daily radiation, which I think would be very reasonable here. Unless for some reason we opted to go with twice daily radiation, this is certainly a patient where he's healthy enough to tolerate a cystectomy as well, it seems. So, if we ever needed a backup plan, we could also think about that twice daily radiation with the induction therapy and consolidation treatment. One of the things I'll just comment on is that, as Dr. Stathey has described it, we've been in clinic together for pre-pandemic for 13 years in multidisciplinary clinics, seeing patients together all at once. And that allows us to really review the imaging and the experience that Dr. Feldman has in the OR to really come together on co-managing these patients, it's of great value.
Yeah, and I might comment just to go back. I'm going to go back a little bit and I'm going to say a little bit of what if. So let me see if I can get back. And I'm having a little difficulty controlling the slides right now. But anyway, so we see that the patient had been referred from outside. And according to the local urologist, it was a complete resection. My first step here, before we even get to the multidisciplinary clinic, if that's not where he presented to, my first step is to say we need to do a re-resection. Okay, we need to really look in, assess, make sure there's not associated CIS. I always do systematic biopsies, or what some people may call a random biopsy of what mucosa looks normal. Make sure there's not, occult carcinoma in situ. Always make sure there's really been, you've got to make sure that you've got local control. The other question then is, what if you look in and, just to get to this image, what if you look in and I think you can see my mouse and you see that there's the tumor here, but you also see there's a small little, what looks like a non-invasive satellite lesion. Does that exclude that patient from TMT? No, it does not. So you handle that cystoscopically, you ablate the tumor. That does not exclude the patient from, as long as there's not extensive disease. So I think that's a really important point, those caveats. So with that, just let's go through to the second case. Okay, case 2. If we got to any of it, just to summarize, it's an 84-year-old frail female. She's got multiple comorbidities. She's got clinical T3 disease, mild left hydro, no pelvic mass, visibly complete TUR, was able to be done with deep fat invasion. There was no adenopathy. She has severe lower urinary tract symptoms, hematuria with clots, incontinence, and reduced renal function. So, Rick, do you want to just quickly comment on chemotherapy for this woman?
Yeah, sure. So she's complicated for any of the treatments that we would be pondering for her significant bladder cancer. Her GFR really precludes the safe use of cisplatin-based chemotherapy. So if she were a cystectomy candidate, I do not believe I would be giving her neoadjuvant chemotherapy because of her GFR. If she were a chemoradiation candidate, and she certainly has features that might argue against that, but also for it, given her age and comorbidities, I think that we do certainly have chemo regimens that we can consider, even with her GFR, such as twice weekly gemcitabine or even weekly paclitaxel.
Jason, any comments?
Yeah, Adam, if you can go back one slide, just so everybody can see the details here. I mean, this case has been set up to be a sort of poor surgical candidate type patient, 84 years old, frail, lots of comorbidities, and they actually had a complete TURBT, so it's setting up to be more favorable for, a less invasive approach, such as chemoradiation, more favorable for that than a cystectomy. That being said, what stands out and what needs further evaluation is the severe LUTS. The patient has a lot of urinary symptoms, has incontinence. And my question would be, was that tumor related? Is that improving since the complete TURBT or not? Is that long-standing? Because, one of the tenets of bladder preservation is that bladder preservation, the question you have to ask is the bladder worth sparing? And in some cases, it may not be due to poor bladder function. And I think we need to get more to that. And sometimes, patients that have very poor bladder function, they're not going to be well served by chemoradiation. Sometimes they are better served by a radical cystectomy and a urinary diversion, and they'll have a better urinary quality of life in the long term. And so I think we need a little more information about that. And I would flip it back to you, Adam, as to, what about a radical cystectomy in octogenarians?
Yeah, I mean, and I'll just comment, that's exactly what happened with this patient. She really had very poor bladder function, and as you nicely stated, what are we sparing? What bladder are we saving? And so, and how does that affect her quality of life? So she actually did have a cystectomy, did very well, and yeah, we know that there's we know that we have a personal experience, but also support in the literature for doing, surgery, radical cystectomy in octogenarians. The majority of them do well. There is probably a slightly higher risk of complication with patients with advanced age, but really they can do very well. So they should not be excluded just due to their age. So we'll get to the next case. 55-year-old healthy male, clinical T3 node positive, TCC with small cell features, pelvic adenopathy, RP adenopathy, and normal renal function. And these images really just, demonstrate the small cell and the positive FNA of the node. And here you can see that the patient had extensive local disease on imaging. So maybe we'll just shoot it to Dr. Lee to comment again about how we should start with this patient.
Yeah. So although, we, as Dr. Stathis described, that, variant histologies can certainly be candidates for tri-modality therapy. In this case, a small cell cancer and the extent of the disease are really driving my thoughts on management. In this case, I would be thinking about neoadjuvant cisplatin and etoposide chemotherapy, which is useful for small cell disease, in hopes of giving 4 cycles and seeing a significant response in both tumor and lymph nodes. How then to think about consolidative management, whether that's surgery or radiation? I don't think that there is any standard at this point, but I think either approach could be very reasonable if this patient's had a significant response to neoadjuvant chemotherapy. Maybe I'll turn it over to Jason to think about his thoughts on radiation.
Yeah, thanks, Rick. Totally agree. Neoadjuvant systemic therapy needs to be front and center in this type of situation, and is part of the backbone for treatment. Adam, if you can flip back again a slide just so that everybody can see again, this was extensive a tumor in the bladder. I mean, just extensive, right? And this is a young, healthy patient. My bias in this situation, if they've had a good response to chemotherapy, is a radical cystectomy, okay, given the tumor burden intravesically, and the ability to do a thorough lymph node dissection that ideally would be therapeutic for this individual, for this patient. That being said, if they've had a phenomenal response to the chemotherapy and have had a complete response, and there's no tumor in the bladder and the bladder is functioning well, and the patient refuses a radical cystectomy or is strongly adverse to it, I certainly think that chemoradiation would remain an alternative option for this patient and could be considered. And as Dr. Lee nicely alluded to, there's no strong data telling us in small cell whether surgery is better than radiation or vice versa. But again, in a young, otherwise healthy patient, I personally would be biased towards surgery.
And I would comment, as we had a question on the next slide about extent of lymphadenectomy, do a radical cystectomy and would do an extended lymph node dissection, going up in this young healthy person, especially with pelvic adenopathy, going up to the bifurcation. So to go to question 4, 67-year-old man who wishes to preserve his bladder, had clinical T2 bladder cancer of the right posterior wall. Complete resection was achieved, had received gem-cyst times 4 cycles and had a complete response, and had a negative CT, and then actually had a restaging TUR and a TUR of the scar post-chemo radiation, had no evidence of any residual disease. And here you can see the resection. But can this patient be safely observed and not undergo cystectomy or radiation? What's the risk? Should he receive any additional chemotherapy? What's the likelihood of bladder recurrence? How are bladder relapses treated? And what's the likelihood of needing a salvage cystectomy and is salvage therapy successful for invasive recurrence in the bladder? So Jason, do you want to attack this one?
Yeah, I think especially with the rise in the use of neoadjuvant chemotherapy before surgery nationally, this is a situation we're seeing more and more. The chemotherapy can be very effective and can lead to complete responses. There can be no residual disease in the bladder. However, I would argue that that does not preclude further local therapy. We know that these patients remain at high risk of recurrence, high risk of future, salvage cystectomy and further therapy. And so I would argue that the standard of care would be to still follow this with local therapy. Now, should the local therapy be a cystectomy or should it be chemoradiation? There, I think you can go either way. And perhaps some patients that have had complete responses to neoadjuvant chemotherapy may be more inclined to be interested in keeping their bladder that has no residual disease on repeat TUR, right? And so these are patients that I think should certainly be offered chemoradiation as well. But I don't think we can preclude further local therapy of some sort for these patients. That being said, it is being investigated nationally in trials in genetically favorable bladder tumor situations, the use of neoadjuvant chemotherapy alone. But I would argue, again, that is very much on a trial situation and generally in genetically favorable situations. There are some other institutional cohorts, Dr. Feldman had referred to these in the earlier discussion as well, that have been looking at this, but I would strongly advise that that is done only in trial sort of situations, and that standard therapy would include further local therapy of some sort.
Yeah, I totally agree. And I think, when you do an aggressive TUR in some of these patients, you might see microscopic disease. And in fact, actually, when you see clinical T0 disease and you see it, and then you, in the cystectomy specimen, you sometimes will see microscopic disease. So the surface doesn't always tell you the whole picture. I think that's really important to know. I think we're ready to wrap up, and I want to thank the AUA and for supporting our course. I want to thank my colleagues and friends, Dr. Evstathiou and Dr. Lee. Pleasure to work with both of you on this course, and appreciate all the time everyone has given to it. And really thank you to all of the staff on the AUA, including Barbara and Aaron and Sarah. Thank you really for helping us to run an excellent course. So with that, if there's any other, I don't believe we have anything else to address. Thank you very much. And thanks to the audience for logging on and participating.